Godt. Så tror jeg stille og roligt klokken her er ved at være 3, hvor vores symposium starter. Jeg kan se, at der stadigvæk er nogen, som dukker til. Det lader vi ske. Vi er rigtig glade for, at så mange har tilmeldt sig det her symposium, som vi har kaldt Exercising with Pain, Living with Pain and Helping People with Pain, hvor oprindeligt så var det egentlig ting som, at vi skulle have et mindre symposium på kandidatuddannelsen for muskuloskeletal fysioterapi. Men vi kunne se, at der var rigtig stor interesse for lige præcis det her emne. Og i de her tider, hvor det er ganske nemt.
Michael, undskyld, jeg afbryder. Der er åbenbart en del, der ikke kan høre dig. Men jeg ved ikke, om det er... Jeg tror ikke, det er dig, den er gal med.
Du går fint igennem her i hvert fald.
Ja, så dem, der ikke har lyd, det må være noget lokalt hos jer.
Godt. Så håber vi, det er nogle lokale problemer, som gør, at der er lydmæssige udfordringer. Kort så vil jeg bare lige byde velkommen her. Også efterfølgende så kommer vi over til de 3 speakers, som jo er dem, som vi alle sammen glæder os til at høre og også diskutere med i dag. Og det bliver sådan, at I undervejs kan stille nogle spørgsmål ude i chatten. Og så samler vi op på de her spørgsmål efter hver enkelt præsentation. Det bliver Simon, som starter, og så er det Ben Smith, og så er det Morten, der slutter af, hvor vi kommer til at lede over i en plenum-diskussion, anført af Morten. Og der bliver tid både til spørgsmål efter hver enkelt speaker, og det foregår på den måde, at over i chatten, der skriver I bare de spørgsmål, som I har, og I kan skrive spørgsmål både på dansk eller engelsk, hvis I gerne vil det. Det er op til jer. Så skal vi nok oversætte, hvis det nu er til Ben for eksempel. Og Ben er fra England, og hans dansk er ikke så godt. Og ellers så vil jeg jo egentlig bare sige, give ordet til de 3 studerende på kandidaten i muskuloskeletal fysioterapi, som jo egentlig er initiativtager til at få det her banket på benene, og til at komme i gang med at invitere den første taler.
Ja, skal jeg så over her, Michael? Ja, jeg hedder Pernille, bare lige sådan kort, og jeg skal præsentere Simon Johansen. Og Simon, han er kendt med i informationsvidenskab fra Aalborg Universitet. Han har han skrev speciale omhandlende sådan udvikling, design, test og redesign af en mobil applikation med det, der hedder Quantified Self-Tracking, som var målrettet patienter med kronisk piskesmæld. Og på nuværende tidspunkt, så er Simon i gang med en Ph.D. ved Center for Almen Praktisk ved Instituttet for Klinisk Medicin. Og den her Ph.D. den omhandler simpelthen konceptualiseringen af en mobil sundhedsapplikation, som er målrettet unge med knæsmerter. Derudover så er Simons interesse og arbejde, det drejer sig primært om områder inden for læringsteori, social kognition, egenomsorg, patientuddannelse og så mere på sådan en teoretisk plan. Simon har selv udtalt, at han er metodenørd, hvor han er meget interesseret i udvikling af kvalitative metoder, og sådan målrettet indfange og beskrive oplevelserne fra sådan hovedsageligt unge patienter med de her muskuloskeletale sygdomme. Så har han tilknyttet 2 vidensgrupper, Up to Youth, som forsker i forståelse og behandling af unge med smerter fra muskler og led, og så Dansk Center for Sundhedsinformatik, som arbejder med forskning, udvikling, rådgivning og undervisning i informationsteknologi til sådan sundhedssektoren. Og så en lille sidebemærkning, det er, at Simon har rigtig meget at sige, så han snakker både meget og længe, så vi holder lidt styr på ham undervejs. Så jeg vil byde velkommen til Simon Christoffer Johansen.
Jamen, tusind tak for den helt fantastisk gode beskrivelse, som jeg synes virkelig rammer essensen af, hvem jeg er. En ting er, at jeg snakker meget, meget længe. Jeg snakker også nogle gange meget, meget højt. Så hvis jeg går igennem i mikrofonen, og det ikke er til at høre, hvad jeg siger, så giv mig lige en melding, sådan at jeg ved, at jeg skal skrue lidt ned. Nå, jeg skal lige have fundet ud af at dele min...
Vi kan ikke høre noget.
Er der nogen, der kan høre mig?
Vi kan fint høre dig, Simon.
Ja.
Okay.
Ja, tak. Ja.
Jeg skal lige have fundet ud af at dele min præsentation her. Så prøver vi lige den der.
Jeg skal ikke gå ind og præst. Jeg var nok lige med en præst, men ja, det er så fint. Men det finder vi lige ud af. Nej, Anna, du skal derop. Jeg tror, du skal derop og gøre noget.
Jeg skal lige høre, kan I se min præsentation nu, eller kan I se min skærm med mine noter?
Noter.
I ser noter.
Gamle
Fantastisk.
noter.
Så prøver vi lige igen. Så skal vi lige se, om jeg kan huske, hvordan jeg gør. Så tror jeg, vi skal have fat i den her. Bliver det bedre?
Ja.
Yep.
Nu ser vi præsentationen. All right, I'm going to switch to English now to do my presentation. And first and foremost, I would really like to thank you for inviting me here to sort of come here and start the ball, as you can say, with these two and clear a pathway for these two interesting and talented gentlemen that will be here after me. And my presentation today is called Reaching the Plateau. And it's sort of like a reflection on how to support adolescents with musculoskeletal pain in developing competency in self-management, which is not directly related to my PhD, but it's nested in the two first studies of my PhD. And I don't think I need to introduce myself one more time since Pernille already did a wonderful job. So I'm just going to jump past that and just go straight into the presentation. Good. Let's see if I can switch this one. Just a minute. Is it changing? Yes, it is. Wonderful, wonderful. All right. First and foremost, I actually planned to ask you if there was any of you who had experienced musculoskeletal conditions, either when you were young or I experienced them quite right now. But of course, this is not possible since we are doing it on Zoom, and that was sort of a little bit of a mistake for me. This is normally what I do when I have presentations. But instead, I'm going to start by telling you that one of the most interesting things that I've experienced as a researcher, doing research into musculoskeletal pain and interviewing patients, getting an understanding of their experience, is getting their descriptions and finding out that these descriptions, they often share this common red thread that runs through them, but also getting this understanding of how each of these red threads, they're always weaving into this complex web of experiences and understandings that they personally develop and how they're often given with their own words. One of the things that I've seen, and one of the key pieces of narrative that keeps on going through in these experiences, is how this condition with musculoskeletal pain often starts out more as a momentary nuisance or as something, like an inkling somewhere in the body and somewhere in the back of the mind where the patient becomes aware of them but don't really pay any attention to them. And this is what I would refer to as more of a molehill, something that is just there, it's a little bit annoying, but it doesn't really do something. But also how these molehills, they're often a start of a slippery slope or trajectory, and where this phenomena that we call the musculoskeletal pain, they eventually grow and they start to intrude into other aspects of these patients' lives and affect them in a very, very negative way. One participant, when we were talking about this, used this terminology of how her musculoskeletal pain, it almost grew into sort of a mountain that she had to carry, or a mountain that was present in her life all the time. And when I asked her, why do you use this description? She said, well, mountains, they're like big, they're heavy, they're huge, they're really hard to ignore and navigate, and they often block the sun and they cast a shadow into other aspects of your life. And I really like this description because I thought that based on my experience, this is a very good descriptor of what a lot of patients have told me. And this is often also when the mountain becomes so big that they cannot navigate it when we see the patients decide to seek treatment. Now, I don't know if any of you who have musculoskeletal pain, because I'm sure that there's some out of you can relate to this experience, at least as adults. I mean, we're professionals, so we normally relate to stuff either from the position of our adult self or from a professional self. But just try to imagine having a mountain in your life when you're an adolescent that just wants to be with your friends, that want to go out and have fun, participate in sports, value activities, and maybe you're even dreaming of having a sports career or becoming, something that requires physical activity in every day. If we take a little bit of a step back, patient education in general, in the way that I see it from my perspective and my discipline, it's always been something, or it's traditionally been something that we as clinicians and researchers, we often address as something that we use to transmit treatment, or like the secret sauce that enables us to deliver the treatment and secure buyback. That is still a good way. But what I'm really interested in is how we can use patient education as a way of empowering the adolescents to climb the mountain, while we with our treatment are actually also reducing the pain, or as we can say, make the mountain smaller again. So this is what I am interested in. This is what I explore. How can we teach patients to become mountain climbers, to climb where they find the plateau, where they can actually, where the sun is no longer blocked out. And this is also what I'll be talking about in this presentation. And I'm having a little bit of trouble switching. Good. We're back again. Just to give you an insight into who I am and what my discipline is. Of course, you know my name already, but now you also know that I have a bachelor and a master's degree in information science, and I'm a PhD student since 2007 here at the Center for General Practice. To give you an understanding of what information science is, you can say that in general, my goal is always dual, because on one side, I develop things that can empower users to think and to reflect about their own practices and develop better ways of solving the problems in their lives, find workarounds, etc. And that involves a lot of qualitative research. But it's actually the other part that I'm going to talk about today, which is I find just as interesting. And that is going out, looking at the ones that we are trying to investigate, and getting some insights into what they do, taking that knowledge back to the information and using that knowledge to challenge our beliefs and our understandings, our perceptions of what the concepts are, because I think that's just important. If we want to understand complex phenomena, we also need to be able to challenge our understandings. And that is sort of the second part of what I do. I normally compare it to being the pit crew in a racing team, where you have other researchers like Clara, like Henrik Riel, who are like the racing cars, you know, they make the RCTs. Us, the qualitative researchers, we are making sure that the cars are going in the right direction, that we are asking the right questions, that we have the right vocabulary to explore what we are doing. So that was a basic introduction to me. You're more than welcome to ask me questions after this if you need any more knowledge on this. Good. So in this presentation, I'm going to tackle 3 questions. First and foremost, I'm going to look at what happens when adolescents experience musculoskeletal pain. What processes does it start? How do they experience this? And what is the trajectory and the different reflections and learnings that they acquire or encounter? Second of all, I'm going to look a little bit at how can we guide adolescents towards becoming more competent in the self-management. That's going to be the last question that I'm trying to answer. And 3, I'm going to look a little bit on how we can incorporate context when educating adolescents on self-managing their musculoskeletal conditions. I'm going to do this from the context of ongoing onset knee pain in adolescents. And what I hope is that by providing you some tips and tricks for how to incorporate what I'm trying to tell you in your treatment, that we can have a discussion on how to do this. Because I don't know yet, and I'm pretty sure that there's a lot of you that have interesting ideas into how we can do this. So with further ado, let's just move on to the menu for today. If we look at how I'm going to do this, then of course I'm going to look at long-standing knee pain in adolescents. We're going to use that as a model case. Then I'm going to present my first study, which looks at the trajectory, and the second study, which is called Searching for the Silver Bullet, which looks a little bit at the context. And then I'm going to provide you with the suggestions, as I just said. Good. Just to get into this, I think one thing that's very important when we're dealing with patients is we need to remember to humanize them. So I'm going to present a case here that's called Frederikke, and I'm just going to quickly read through it. And there is a point to it, so stay tuned. We can say that Frederikke, she's just turned 15. She's in the 9th grade, and she's sort of doing okay in school, even though she thinks that homework is a waste of her life. She's always been an active girl, but since she joined the first team at soccer practice, the soccer has started to take up all of her time. Several of her friends, they're also soccer players, and she really enjoys going to the clubhouse and hanging out when she is not having practice herself. During the last 4 or 5 months, she started to become aware of her knees. It started with just this odd feeling when she was negotiating stairs, and later she started noticing how her knees would sometimes feel old during soccer practice. But this often passed as she warmed up. Frederikke, she's had sport injuries before, sprained ankles and pulled muscles, but this feels different than all the other times. Still, she's been able to keep up with her teammates, and she reckons that this is probably just nothing serious. When mentioning it to her parents, she was just told that this is just growing pain, and this set her at ease when she did this. She bought into this explanation. But during the past 2 months, Frederikke has felt this tingling and throbbing sensation in her knees, especially after matches. Sometimes it's been so bad that she's had to go lie down once she got home from soccer practice. Another thing that's happened is that her knee has started to giving up when she plays soccer, and she's had to lower her tempo to cope with this. This frustrates her quite a lot, but still she hasn't told her coach or her parents or her teammates about this, especially because she's afraid that they might think that she's whiny, lazy, or perhaps even kick her off the team. But now it's become so bad that she's asked her mother whether this experience that she's having with her niece is actually normal, as a way of testing the waters. And her mother has agreed that she should have a break and go see a doctor. So this case, Frederikke, is not a person, but it's sort of like a construction made of 14 patients from one of my studies, and basically just a summary of their experiences as a whole with a human face on it. But still, this gives us quite a good picture of what kind of patients are that are turning up in general practice. This is when we first see patients like Frederikke as well. Another interesting thing that I would like to just to note is that how much of this, if we look at it, is about pain, that's the red dots, and how much of this is about everything else. Just think about it. In general, if you look at it, then you can see that there's a lot of other things going on. There's a social dimension to this, there's a experiential dimension, a cognitive dimension, a lot of other things. And I think it's Strauss and Corbin that talks about 3 lines of self-management, where pain management is only one. And this sort of feeds very well into the rest of this presentation as well, where you can talk about when we are saying self-management, are we talking about you're managing yourself? Are we talking about that you are managing the self? Think about this, because I'll return to this question later, and for hopefully we can discuss this as well. So the question is, how common is Frederikke? Well, we know that knee pain is extremely common in adolescence and is associated with disability and lost quality of life. If 1 in 3 adolescents, they experience musculoskeletal pain between the age of 10 to 19, then knee pain will account for almost a third of all complaints in this group. We know that half of the adolescents who experience this condition, they will recover, thank God. But the other half, they will continue to have pain for 2 to 5 years. And from this, almost 75% will have to cut down on their sports and their, how can you say, participation in value activities to cope with the pain. The question is or we can say, this is an issue, and why? We know that research has shown that experienced physical limitation during adolescence is linked to increased risk of obesity and poor health, low self-efficacy, and a myriad of other issues when in adulthood. And a recent study made by Henrik Riel, amongst others, have actually shown that this is also the case with adolescents or adults who have grown up with knee pain as adolescents. We know that interventions and exercises and patient education, they can significantly improve the individual prognosis of patients if they're given at the right time with the right instructions. But one of the major challenges that we have right now is that our lack of insight into the social cognitive processes that governs the adolescents' formation of self-management. I mean, what is it that makes them form and integrate self-management into their daily practices? This is a barrier for actually enhancing the efficacy of the treatments that we have right now that are working well. And this is also the basis of my first study as well. So the first study was called Pain Stories, and we wanted to explore this problem of not really knowing what the trajectory for adolescents are and how we can support them to transition into self-management. So in our naivety, we decided that we wanted to explore the challenges and barriers and self-management needs of adolescents with ongoing onset knee pain, a qualitative study. And we thought how to best do this. This would be to interview some young adults who have experienced the entire trajectory and do extremely deep interviews with them, semi-structured, to get an understanding of what their barriers were and throughout their experience as well. So we included young adults who have had this condition from age 10 to 15. And to sort of grasp the trajectory of the condition as well, we incorporated what we call a memorization exercise, which is the second picture. So apart from interviewing them, we actually asked them to fill out this graph where we would basically say, okay, when did the knee pain start? What happened? And they would sort of like create more or less a trajectory of their entire condition. And all participants did this as well. This was also a very valuable tool when we wanted to interview them because we had a very good overview of their conditions. And these conceptual graphs were included as part of the analysis as well, chopped up, and we created, we found the different phases of the trajectory. What were they in alignment about? And then we used this to form a matrix where we then incorporated the qualitative data. So we had this really, really complex system where you could see the different phases and what were the meanings and experiences of this. Good. The findings from the memorization exercises actually yielded some really, really interesting insights. First and foremost, we could see that there were different. We got this overview of the temporal phases and the sort of like reflections that the patients had to go throughout their different the different trajectories. And from there on, we could create this flow chart, which basically shows a lot of reflections. One of the key things that you can take away from this, I'm not expecting you to understand this fully, was how there was this consensus that there were basically 4 phases that that basically repeated themselves throughout the patient's journeys, and that was a phase and a reflection of acknowledgement, a phase where they were exploring practices, a phase where they were looking at maintaining balances also as a reflexive practice, and finally a reconceptualization of self. Another thing that we also noticed was when we looked at this flowchart was how that you could say that their management and their journeys were sort of like basically constructed out of 2 feedback loops, if you could call them that, where you would say the first part of it that you see in the upper part of the model was geared very much towards what we call retention, holding everything together, keeping their connection to the sports, keeping their connection to their friends, and basically keeping on doing the same thing that the adolescents would always have done. And basically, you could say that you could see that there was this process where the patients would reduce their praxis until the pain leveled out, and then something external would happen, and then they would reduce their praxis again. And then there was this turning point, which happened in acceptance. And all of a sudden, we saw a change with acceptance, where the patients would look at, instead of reducing the praxis whenever something happened externally, they would look at expanding their praxis instead. So that was a second loop. And we knew that acceptance had something to do with this, but what we were not 100% sure of. So if we look at just a quick overview of the qualitative data from the analysis, we by subjecting this to thematic analysis, we could see that it created 4 clusters, 12 main categories, and 28 subthemes. And if you look at the clusters, you could see that they very much resemble the same phases that we found in the flowchart as well, where we had one that we called the apprehension barrier. We had one that we called the knowledge barrier. We had one that was more geared towards social values, and the last one that was geared to context of its own. So we had a match between these clusters. And we could also see that there was sort of like a hierarchical relationship, which was basically most clear between the learning and the behaviors cluster. But this is a little bit hard to see because this is a reduced version of the system. The original system was a lot bigger and had a lot more subcategories, but it couldn't fit the screen, so I had to reduce it. From this, we were able to devise 8 categories, which formed the basis of our analysis. And I'm just going to go through these categories based upon the conceptual model that we extracted and tested with participants as well, to give you an understanding of the trajectory as it is. So we're going to start with theme 1, which is called the first experience. And I've selected a quote just to show you how this theme basically, what the essence of this theme is. And this is a young girl called Pernille who told me that she describes, I was a major question mark because I've never tried this before. So my first thought was that there was something wrong. But since it just kept going on and on every day, I didn't put any meaning into it, because it was primarily when I walked up my stairs that I felt my knee pain, and I did not feel it anywhere else. So it gives a pretty good description of how she felt the knee pain in a certain place, and how it it was only when she felt it that she paid any mind to it, and how it disappeared. And this is basically, so this is also described in the model as the first experience, which is sort of like a round circle, because there's no meaning into it. And this was generally a common experience or common description, that the participants did not have any meaning to put on their pain when they first felt it. And generally, they described how they would often feel their pain in many different ways the first time they noticed the knee pain, just from a tingling sensation, throbbing, or having a ball in a knee, or band around the knee, or simply just the knees giving up, and how they did not necessarily associate this with something that would stay and develop into something that would eventually start to affect their lives. This also fits very well with how the knee pain was often interpreted as something momentary that was either related to a certain situation or certain activity, and was often forgotten once they got to once it was not there anymore. So the second theme that we found in our analysis is what we call the double bind. And the quote for this is, "I didn't want to be the one where people would think, oh, she's just so annoying because she is going to affect our performance. I didn't want to be her." And that was also how I had it during my preschool. When we were doing running or during gym class, I was not going to be the person who was going to slow the team down. The double bind is where things starts to heat up, because this is sort of like described as how the participants, they reach a threshold where the knee pain starts to get to a point where they cannot ignore it anymore. So it starts to transcend into other areas of their life. Maybe the knee pain will start to emerge when they're doing sports, or then start to emerge in different contexts where they would normally not feel it. And this is when they start to worry. One of the really interesting findings is how our participants described this, how when the knee pain would emerge in different contexts, they would have to make judgments on what to do. So they could either manage the social situation and what they were doing, or they could look back and stop what they were doing and manage their knee pain. A lot of participants also described how they felt that managing their knee pain would actually make them vulnerable to being judged by others, or being suppressed to stigma or stuff like that. And especially like being branded as being whiny or being lazy, or just somebody who's attention seeking, was something that really was a common theme in a lot of these interviews as well. And another thing that we also found was how sports became transactional. So what they described was how once the knee pain got to this point, they would actually go back and try to participate in sport. And when this happened, they would feel better, they would feel calm about their knee pain. But once they failed to participate and make the transaction, they would actually feel worse, and it would actually make their what do you say, their anxiety worse, because the knee pain was also a cause of anxiety, where they would think, okay, how is this going to affect my life? Can I be the person that I want to be as well? Relates quite to identity. The third theme was connected to this, and it was called functional theories, and it related a lot to the theories they formed in the mind. One of the participants said, my grandfather had arthritis, so I thought that this was just part of being an adult, or a person in a way, and part of growing up in general. Functional theories was something that that a lot of participants also spoke about as well. That in order to sort of quell these negative emotions that would often be associated with failure to participate, they would often create these theories in their mind on what is actually wrong. And this is a way of both dealing with the negative emotions, but also to give some kind of sense to the knee pain as well. And these functional theories were often placeholders, and they were more or less developed from a child logic and based upon the observations of others and how they reacted to the pain. We had a whole list of these. I'm not going to go through them. Getting a name was the fourth category, and this often related to when they got to the doctor. One of the participants described how once she got to the doctor and the doctor gave her diagnosis, she was just told that she fits directly into our project and there's not anything else that she can how can you say that she can actually that could actually be the problem, and she felt like this was a relief as well. So this is when we get to the acceptance, because this getting a name was often associated with relief and some kind of removal of doubt, because doubt was a great issue as well. Apart from the negative emotions of not being able to perform, doubt was also something that kept on reemerging as a theme. But getting the doctor's diagnosis and a name would actually remove doubt, and it would also give them something that they could tell others when others were accusing them of being lazy or whiny. So it made it permissible to start managing your knee pain as well. And this ties very well into theme 5 and 6. And this is where we see the turn in the other model as well. One participant described that, well, the longer I went around with my knee pain, the more conscious I became about my condition and what I could do about it, because I learned that now it is painful, so now I need a break. And gradually I became better at making the right decisions and doing the right things so that I could become ready for what I would rather use my strength on. So I took these two themes together because they were sort of interconnected, where you can say theme 5, which was related to the context phase as well. This described how, because it became permissible for them to manage the knee pain, we would see how participants would often go back to the sports and how they would start to, take breaks whenever they needed that, or slower the tempo because now that was something that they could. And they generally described how being sports active actually made them look into, or made them aware, and they started to pay attention to the symptoms. And some of them described how they could actually start to feel new nuances in the pain. And this is where it becomes really interesting, because a lot of the participants used the term finding the limit as a way of describing this. And they were all in connection with this. And in general, how they had to manage 3 things. They had to learn to find the limit, they had to learn to hold back, and they had to learn to push forward, and how that sort of became the core of managing the condition, something that they expanded on through more complex behaviors at the time. As they became better at managing their conditions, we saw this move into what we call the context phase, where they started to look at not necessarily their behaviors, but they started, or different situations and what happened and how to apply the behaviors. But they started to look at different situations and how each situation would affect the development of the condition as well. So that was sort of that was the most interesting finding from that, and how, but also how that motivation generally became something that drove this forward. The final phase was reconceptualization. One of our participants told me that it was first when she became pregnant, then, and when she had her son, that she became aware that there was some things that she wanted to do when he became older, and therefore she had to manage her condition better. And this was the final phase that we looked at as well. And in this phase, we can see how they started to get a better understanding and how to integrate their understanding of the injuries into their personality. There was also a question of how in this area, how a question of how sort of like they started to plan for their knee pain and to understand that this was part of their conditions as well. They started to reconsider their life goals and describe how they would sort of like change their value systems to accommodate the knee pain.
Du har 5 minutter igen, Simon.
Hvad siger du? 5 minutter igen?
5 minutter igen.
10 minutter eller 5 minutter?
5.
5. Okay, så har jeg godt nok travlt. Nå.
Du tager 10 til bruge det.
Giv mig 10 minutter, hvis det er det.
10 minutter.
Good. First and foremost, if I'm just going to summarize the insights, then we can say that if we look at what happens when they experience musculoskeletal pain, I think the first thing that you need to take away is that the knee pain and the management of knee pain does not come necessarily from a desire to just get well. It also comes from a desire to control the situation when where the knee pain has actually happened, because the knee pain creates an uncertainty for the adolescents. And we can say that another thing that you can take from this is that self-management is both social and biological an activity, and it's aimed at creating order. And this can both be reducing the pain and reducing uncertainty. And we can talk about how their efforts to self-manage contains elements of both inquiry and exploration as well. And this work towards mastery of knee pain is a 4-stage process. So there are different needs and different challenges from each stage as well, something to understand and consider. And barriers for self-management, they would often emerge as dilemmas. Dilemmas as, should I tell my parents and risk being cut out from sport? Or should I ask for help? Should I lean into the pain or learn to hold back? Should I go with the motivation, or should I learn to make compromises? Furthermore, we can talk about how acceptance is essential for self-management, and how balancing the concept of leaning into pain, finding the limit, and holding back, they are highlighted as core skills for management. And these are something that you should build on. Because I only have a very short time left, I am going to skip a part of my presentation because I don't want to take the time for the rest of the people. But what I'm just going to go forward to really quickly is that the second study was a workshop study where we were trying to look at the context for how a mobile application should work. And one of the most important findings that we can take from here was how when the adolescent enters into treatment, this starts a complex process of interactions between the adolescent, the parent, and the GP. And I know this is a confusing figure. I am not expecting you to understand it fully. But the way that we normally saw it was that we had these 3 roles that would be established, where the adolescent would be the explorer, who would try to understand their own condition, which fits quite well with the description from Pain Stories. We had the GP, who had the role of the one who would try to sort of navigate and help the adolescent navigate this explorer, who would give advice and who would help them to become more capable of this exploration. And finally, we had the parents who had the role as the advocate, who would both negotiate on the adolescent's behalf, but also help the adolescent with managing their knee pain as well, and figure out how to incorporate the advice of the GP. Furthermore, we saw that there was a large contextual system between that. So the parents would also navigate with or negotiate with teachers, coaches, and other parents as well, and include them as proxy parents that could help the adolescent becoming better at managing their condition and keeping tabs on them as well. Whereas the GP had they had a lot of systemic challenges that they needed to adhere to. And finally, there was friends and peers and social roles that the adolescent had to navigate to. But the biggest challenges that we saw in this study was basically how parents had really difficulties explaining this condition to others, the difficulties seeing when the adolescent actually had pain and when to contact the GP. And finally, the GP had problems understanding the adolescents, and adolescents often had issues putting the right words on their condition and explaining how it developed for more than a few days. So that was one of the communication system problems that we also saw. I'm just going to round off right now.
Ja, du har 5 minutter tilbage, så det passer.
This is perfect. Wow. Good. So just from what I have presented already in these two studies, and I'm sorry we didn't get the context of the workshop with. If you want to know more about it, please just give me a shout either in the chat or send me an email. I'll tell you about it. But based upon the findings that I've presented here, we can say that if we want to support the adolescents in becoming more competent in managing the knee pain, there's certain things that we need to understand. First and foremost, we need to think about how this is that competency in general. If we look to learning theory, it's not something that we can just tell people to become. There's this element of transformation in competency, which means that the adolescent needs to go home and try things out and find their own way into this into the and sort of like make their own practice with managing. Second of all, we say that self-management is sort of like a complex activity, which apart from just limiting pain, also brings order in things. And I'd really like to stress this. This is also, Debbie Kralik also describes it this way in one of her studies as well. Wonderful qualitative study with adults with chronic conditions. And finally, you can say that what is that patient education, sort of like when we are educating, we have this inside and outside dichotomy, which you could see at the model. So as educators, we need to think about what we are doing in the situation, how it affects outside of the situation. We can say that if I have to give some suggestions, I can divide them in two, and I really like your feedback on it. Part of it relates to the trajectory and how to empower the adolescents and their inquiry into the condition and their efforts to make order. And one of these things we could do is hear, listen, and ask questions. Another thing could remember that adolescents, they self-manage to make order, and if our treatments does not add to this order, then it's not necessarily sure that they'll do it. Provide a diagnosis and name quickly. Address their functional theories, their perceptions of what the condition is, and align them so that they have a better chance of making sense. And finally, normalize the condition as much as possible so that they don't feel that they stand out. Another part of it is creating a viable learning environment, which is why I brought the picture, because that's what our public schools really good at. And that requires multiple sessions, include the adolescents and the parents, and help them to set goals for what they want to achieve. Include the parents as an ally as well, provide them with the information they need so they can negotiate for the adolescents with other parents and with the school and whatever it is, even give them information. And if the adolescent brings tools into the situation, then let them do so, because if they bring a tool, they've thought about what they use, what they need, and they might not help, but they are still there. And I think that was it. That was my presentation. Thank you a lot for listening. And I'm ready for questions.
Ja, lige for at lave en kort opsummering først til dem, der ikke fangede det hele, jamen så vigtigheden ved det her, det er det her at få det her navn på, som Simon siger, og forklaring som for de her smerter, og lige så meget mekanismen bag, og grunden til, at Simon også snakker om det her, det er ligesom fordi, at det er lige så relevant som de her knæpatienter, som det egentlig er for alle andre. Så noget af det her med at lytte, stille spørgsmål, der skal noget navn på, den her tro, den skal vi egentlig rykke lidt med, og så er konteksten rigtig vigtig. Og så som du siger, Simon, her til sidst, jamen det her læringsmiljø, som egentlig er mellem behandler og for den sags skyld patienten, jamen det er også rigtig vigtigt, og det er vigtigt at stille nogle muligheder op, sådan at alle kan lære noget. Så pointen, ligesom med Simons oplæg her, jamen det er, at det dækker for alle de her muskuloskeletale skader, det vil sige både inden for muskler og ledproblematikker, og skal ikke kun bruges på unge med knæsmerter. Er det korrekt, Simon?
Generelt, ja. Altså, man kan sige, nu bruger vi jo ligesom knæsmerter som modelcase, og det er fordi, det er ligesom dem, vi arbejder med. Men vi regner med, at fordi de her problemer, de er ikke nødvendigvis møntet på sygdommen, men de er sådan mere møntet på det generelle omkring læring og alt det her, så regner vi med, at de vil selvfølgelig ikke kunne overføres en til en, men vi regner med, at der vil være en overførsel til andre former for muskuloskeletale sygdomme, på samme måde som vi kan se med andre former for læring, når vi taler. Altså, vi kan generelt tale om det begreb, der hedder transference of praxis.
Ja. Godt, så håber jeg alle er med. Der er kommet et spørgsmål til dig, Simon, her. Du sagde noget med, at I fandt ud af, at forældrene havde forskellige oplevelser under slides finding a complex system of interactions. Kan du beskrive det kort?
Forskellige oplevelser. Ja, det er et godt spørgsmål, fordi oplevelser kan være mange ting, men vi kan snakke om forskellige roller. Er du sikker på, at det ikke er det, der menes?
Det vil jeg gætte på.
Ja, altså vi kan tale om, at forældrene... der kom lige en besked, der det kan være det smart.
Nej, det var
må jeg gøre det på dansk?
Ja, det må du gerne.
Altså, vi kan jo tale om, at forældrene ligesom at, hvad det nu det hedder, at den unge og den lægen har en rolle, så får forældrene også en rolle, lige så snart de går ind i det her, i behandlingssituationen. Og deres rolle bliver ligesom sådan at stå bag ved den unge og sørge for, at alting, det fungerer sådan, at den unge og lægen, vist vores data, kunne have en ordentlig samtale, og derefter sådan ligesom sætte scenen for, at den unge så kunne passe på sig selv på bedst mulig måde. Så der var den her indenfor og udenfor, hvor man siger, indenfor, der forhandlede den voksne på vegne af den unge med lægen. Så hver gang, at samtalen den ikke gik ligesom den skulle, så kunne den voksne lige tage over og fortælle, jamen det er sådan her det er. Det er også det, der nogle gange ikke lykkedes i den kliniske situation. Og lige så snart vi kom udenover, så havde den voksne rollen, hvor de sagde, så forhandler du med læreren, sørg for, at læreren ved, at den unge har et problem, at gymnastiklæreren han ikke tvinger vedkommende til at løbe en maraton på næste fredag. Sørg for, at de ved det til fodbold. Sørg for, at der måske er en anden forælder, der kan holde øje med den unge, og lige huske, at øvelsen bliver lavet, når de er over at besøge kammeraterne, eller hjemme at besøge fætter og kusine. Så det var sådan meget det der med, at der var nogle forskellige roller, der ligesom skiftede. Og derudover så havde forældrene også den rolle, at vi ligesom sagde, de ligesom stilaserede, hvor man ligesom kan sige, jamen sørg for, at de får lavet deres øvelser, sørg for, at de får taget ordentlig vare på sig selv i situationen. Så det var sådan ligesom de roller, som vi lige umiddelbart så. Der er sikkert mange flere, men vi havde kun en workshop med, jeg tror det var 13 forældre.
Godt. Jeg håber, at du fik svar på dit spørgsmål. Der er kommet et mere her. Er der nogle andre gode forklaringsmodeller? Nu brugte du bjerget, som er god. Jeg finder ofte, at en god forklaringsmodel er perfekt, og en perfekt icebreaker til at bedre forståelsen af smerten på et niveau, som patienten kan følge med på. Har du andre forklaringsmodeller eventuelt?
Altså nu lavede jeg bjerget i forgårs, så jeg må nok indrømme, at den bruger jeg ikke så meget, men altså, jeg har jo hørt mange forklaringsmodeller fra de unge selv, og altså, de spænder jo fra alt muligt til, der sidder en lille mand inde i mit knæ og trækker i et eller andet, så det strammer hver gang, til at jeg har en slidskade eller en brudskade. Men jeg kan godt lide, hvis man skal forklare de unge, hvad de skal gøre, så synes jeg, det er meget interessant, at de bruger noget af det samme sprog. De snakker meget om det der med, find grænsen, og så skal du presse fremad, altså, eller pres dig selv en lille bitte smule. Og også igen den der med sådan ligesom at holde tilbage og spare op og alt det der. Så jeg tror, hvis man skulle have en god forklaringsmodel, så udover at have en historie som bjerget selvfølgelig, så er det også et meget spørgsmål om at matche det sprog, som de unge allerede bruger. Fordi igen, som sagt, de bruger meget de samme termer til at forklare, hvad det er, der sker. Noget, der faktisk overrasker mig rigtig meget.
Ja, det går...
Jeg håber, det var svar på det spørgsmål, der blev stillet.
Det lyder det som om det er, ellers så må du sige til, Christian, kan jeg se, det er dig, der har stillet spørgsmål. Ben har et spørgsmål, som han gerne vil høre, om han må stille direkte gennem video.
Yes, of course.
Yeah. Ben, it's your turn then.
Should I stop sharing?
Yeah, you can do that.
Hey Simon, great talk. Thanks very much. I really,
thanks.
Really found it interesting. I'm frantically thinking that I needed to rewrite my presentation now.
I'm sorry.
I just had two questions that popped into my head. The first one is, in your first study, you talked about how some of the participants sort of attempted to go back to sport, and then talked about how some said they failed or didn't fail, and how they responded to that. What do they define as failed?
Well, I think that it's a little bit more complex than that. First and foremost, we saw that, I'll just take this from the beginning, because first and foremost, we saw that a lot of the participants, when they contacted the doctor and they didn't get a name, they decided that, okay, it's probably just me that's wrong. So I'm just going to try to go back to sports and do whatever I did before. And they, of course, would go back and they would have pain still, and there wouldn't be any development in their understanding. And eventually they'll have to seek out the doctor again, and then they got a name. I think we had like 3 or 4 participants that actually gave me that story. Another, how can you say, another description that was how they, when they got to the context phase and they thought, okay, I can manage this now, my knee pain is sort of stable, because it doesn't necessarily, at this stage, it doesn't fluctuate, it just stays stable. Then they decided, okay, I'm going to try my hand at soccer again, or I'm going to try something new like running a marathon. And one failure could be re-injury. We had a couple who actually tried running a marathon, they actually re-injured themselves. So that was how they would describe failure. Another way of failure would be sort of, I don't think it was really a failure, but going back to sports, trying to compete at the same level or up to the same level as they did, and eventually realizing that that was not what they could do. That was not possible anymore. So from there on, learning to make compromises in the way that they did. We had one patient who described it really, really well, because he said that he returned to soccer and he wanted to go back to, you know, like the first team, but he couldn't. So he decided that, okay, instead of quitting, I'm just going to drop a team down, and then I can still be sort of in the middle as a player, because I didn't want to be like the worst player on the first team, and then I could still have some joy. So it was sort of not necessarily as you can say failure to participate at the level that they were at, but then on the other hand, gaining another view of how participation could be. So in the failure was also winning something else. Did that answer your question?
Yeah, it did. Yeah, really interesting. Thank you, Simon.
Thank you.
I've just got one more question if we've got time.
Yeah.
I think it was your second study, but you talked about how some of the participants sort of recognized that they felt better. Well, there was some satisfaction with getting a diagnosis.
Yeah.
And so I think I often worry, and this is just sort of my opinion rather than anything from the data, although I think there's something in the back pain literature that sort of backs this up a little bit. Yeah. I often worry that by giving people a diagnosis, we perhaps might make their short-term satisfaction better. But I'm often worried about actually the impact of that in the long term. Is there anything from your data that, you know, might be able to answer that?
No, and that's actually one of the blind spots in our study. Because this is a qualitative study and the patients that we worked with, more or less all, I think that we only had one, and this is from the first study, had a diagnosis and actually went through this. We can only see how the diagnosis actually changes their perception of what it is, because it sort of changes their ability to look at the phenomena of the knee pain and to react more proactive on it. Once again, because it removes some of the stigma and the shame of having something that's undefined, and then one more time also provides them with an answer they can give, which makes it permissible for them to self-manage. So that's the benefit that we see from it. But the one participant, now that I think about it, who didn't get a diagnosis, also had this experience of gaining acceptance, but it was way further in their how can you say trajectory. So they used a lot. This person used a lot more time to get to that recognition as well. I mean, because the diagnosis was also a facilitator of acceptance, because okay, this is what it is, removes doubt, and now I can do something. But I can see the dilemma, and the question of what would have happened with the reconceptualization and finding yourself. I mean, are the patients that we've had just the good stories, if you know what I mean? That's a question I cannot really 100% answer from the data that I have. So I think that's the best answer I could give you.
Thank you.
Godt, så er der lige en ros fra Christina, som synes, det er dejligt, der bliver forsket det her, hvor der både bliver kigget på det sociale, det kropslige og det diagnostiske. Så det får du lige en ros for i forhold til den her smertepatientgruppe. Og så har Jonas også et spørgsmål, der også lige bliver live.
I'll try in English as well, just so everyone can keep up. I just wanted to know, you used the pit crew analogy in the start where you were sort of like laying the foundation. So what do you see as the next step for this self-management intervention research? And on top of that, I'm particularly interested in the context limitations, like the GPs. You said they saw time as a context limitation, for example. Like, could you expand on that, the next step?
Well, first of all, my analogy of the pit crew was more or less related to myself and my work in the general practice. I mean, I think I was the first qualitative person that they sort of got in the door. And now we are three. So we are sort of like the ones who are looking into the complex phenomenon and trying to get the better understanding for the organization as a whole. So that was sort of the analogy, just to clarify that. But if we look in relation to self-management and my understanding of what I think the next field is, the next step within self-management research. First of all, I think that both when it comes to patient education and self-management, there's so much stuff that we still need to understand. It's a lot more with the processes and to get an understanding of not necessarily each psychological process, but also how these processes interconnect so that we can start to make workable theories for how patients learn and understand. And this is very much, and this comes from an understanding of how learning is sort of like something that we happen in a way that we negotiate the world. But what does it mean when our body is actually an obstacle for negotiating with the world and what is around us? And I think that also, while this is one important topic and where the research is at right now, understanding how, what can you say, how the contexts in general, not necessarily only the clinician's context, but how the context around the person who's trying to self-manage, how they actually influence self-management, because this is where we can do something. One thing is to give them interventions, but how do we create contexts and environments where this learning, which is connected to self-management, will actually happen, and where you can have this transformation of knowledge, which is required for you to become better to self-manage. I think that's the next important step, at least for research into both self-management and patient education as well. I hope this answered your question.
It did. Thank you.
Thank you.
De resterende spørgsmål, dem gemmer vi til diskussionen, og så vil jeg give den videre til Jonas.
Hej alle sammen. Jeg skal præsentere Ben, og det kommer jeg lige til at gøre på engelsk også, så Ben han er med. Jeg ved ikke, om du kan stoppe med at dele din skærm, Simon.
Jeg holder lige op med det, men det var lige det, jeg skulle til. Så.
Det er godt. So Benjamin Smith is a clinical research physiotherapist based at the University Hospital of Derby and Burton, and he also holds an honorary assistant professor's post at the University of Nottingham. Ben's main interest is in the management of persistent musculoskeletal pain and the role of exercise and physical activity in prevention and treatment. And he's particularly interested in the role of pain with exercise, which his talk will probably reflect. Besides his work in research, Ben still maintains contact with the clinic, working 1 day a week in a physiotherapist's department at the hospital. So without further ado, I give the word over to you, Ben, and I hope you'll enjoy his talk.
Thanks very much. Thank you, Jonas, for the introduction. Can you see my slides okay?
Yeah.
Yeah, brilliant. And thank you, Michael, for inviting me to talk about my work. So yeah, I'm going to be talking about pain and exercise, and specifically how pain fits into exercise prescription and how we might be able to use it to our advantage. So for those who don't know me, and I'm a clinical research physiotherapist based at Derby and Burton Hospital with an honorary assistant professor at the University of Nottingham. Just to give you an idea of where I am, that's where I'm based in Derby. And it's about 30 kilometers between Derby and Nottingham, and I normally try and cycle it, although I haven't this year. And Google Maps tells me it's 69 hours cycling from Alberg to Derby. So next time Michael comes over, I challenge him to cycle that distance. A lot of the work I'm going to be talking about is in collaboration with other researchers. So I'd like to thank all of them for their contribution to my work. And I'd like to start by discussing some case studies. I'd like to use these case studies throughout this presentation, and I want you to keep them in mind, and we'll visit them at the end. These are real case studies. They're ones that I've used quite a few times. They were ones that particularly informed my thinking a few years ago when I was developing some of my initial ideas and developing the ideas of what I was going to do for my PhD. So this is case study one. This is a 63-year-old male who has a 10-year history of neck pain, is not working because of the neck pain, has had multiple previous treatments, GPs, pain clinic, orthopedics, physiotherapy, back and forth between primary and secondary care. In the past, tried to buy a treadmill, but finds it too painful to use. And GP has referred back to physiotherapy. So this patient came to see me probably about 5 years ago now. So what's the best advice we can give this person, this patient? What is the best evidence that we have that can inform how we treat this patient? And how can we use a biopsychosocial approach in a busy clinic to help this patient? Now, I work in a secondary care hospital in the UK, so a public hospital. And so people often say to me, well, the patients I see are different to the patients they may see in private clinic or sports. So here's another case study that I like to talk about. This was a 23-year-old female with lateral hip pain who was a 400-meter runner. So very high level amateur athlete, not quite professional, but high level amateur in the UK with a 1-year history of lateral hip pain. Would normally train 4 or 5 times a week. Complains that whenever she ran harder or faster than about 60 to 70% of effort, then it would result in pain, and it would often take 2 or 3 days to settle after that. Struggles to weight bear after she did running training sessions, and then so generally now avoids running. Still trains 4 or 5 times a week, but lots of gym-based work and exercise, sort of class-based activity, and is avoiding sprinting. Really wants to be pain-free before she sprints again. Physiotherapy in the past included clam exercises, core stability exercises, bridging exercises. I suppose what I would class as traditional exercises. And she came with phrases like, I know I've got weak glutes. I know I've got a weak core. I know I've got an anteverted hip. And wanted to run, as I say, only when she was pain-free. Another case study, 32-year-old female with a 3-year history of patellofemoral pain or anterior knee pain. Again, would normally run 4 or 5 times a week with multiple previous physiotherapy interventions that really haven't helped her. The last physio that she saw, when she attended and said that she wasn't better, sent her for an MRI scan. And the MRI scan showed cartilaginous loss with osteochondral injury on her patellofemoral joint. So the physio then told her that maybe she should consider non-weight-bearing exercises. So a 32-year-old female, and the physio told her, well, don't run, don't do weight-bearing exercises, go and swim. And a friend of a friend, she knew that I was doing a PhD in patellofemoral pain, and that's how she ended up seeing me. So I think a really interesting case study. So keep those in mind throughout my presentation. So Michael has asked me to talk about, is it okay to have pain during exercise? Can it be an advantage that the patient feel a bit of pain when they perform exercise? And how might we implement a patient-centered biopsychosocial approach in a busy clinic workday? So let's have a look at that first question. Is it okay to have pain during exercise? I guess if I was being facetious, I would say, well, why not? But one of the things that interests me is pain in exercise is that I think it's become a bit of an elephant in the room. Researchers traditionally ignore it. So trials and interventions that go through randomized controlled trials and research, the researchers typically ignore the element of pain with the exercise. And I think clinicians have become fearful of it and clinicians ignore it. But is it important? Well, as one patient put it, it's, are you making it worse? And that's the crux of it really. As I'm doing it, exercise, and this is hurting, should I really be doing this? Or should I pack this in and do something else? It's the not knowing. Another patient, well, it makes you wonder. Sorry, another patient, a physio told them to do some exercises and another physio told them not to do some exercises until they were pain-free. So this patient said, it makes you wonder which one to believe. Because I'm like, well, okay, this physio told me not to do anything until I'm pain-free because he doesn't want to aggravate it. But then she said, another physio, that I would probably be best to start putting on impact again. The result was that this patient had what I call confusion paralysis. They didn't know what to do, so they didn't do anything. They stopped exercising. Well, how does it fit in with the clinical perspective? What do clinicians think of pain and exercise? Well, as I said, my view is clinicians are largely fearful of it. And to my knowledge, there's only been 2 studies that have looked at physiotherapists' attitude to pain and exercise, and particularly their belief and attitude to pain. So the first one was Chris Littlewood in 2012, who looked at physiotherapists' attitude to exercise with shoulder pain. And his survey demonstrated that 44% of physiotherapists would encourage their patient to stop an exercise if it was painful, with the remainder of the physiotherapists saying that they would only encourage their patient to continue if the pain was below a certain level and a whole range of scores given. So again, I'm interested in where those scores come from. What makes a physio decide what pain level is okay and not okay? So I conducted a similar cross-sectional questionnaire looking at patellofemoral pain in 2017. And similarly, about half of the physios would tell their patients not to continue with an exercise if it was painful. And again, the remainder of the physios said that the patient could continue if the pain was below a certain level, and a whole range of scores given. I also asked about sport and leisure activities, and overwhelmingly the physiotherapists would also advise their patients not to continue with sport or leisure activities if they experienced any pain, with the remainder of the physios again saying only continue if the pain was below, and it ranged from 1 up to 6 out of 10. Some use words like moderate or mild to allow the patient or to advise the patient to continue with their pain. So from a public health point of view, from population level data, what would be best? What would help the population better for the advice that we're given? What does the research tell us? So although there is limited data, what does the data tell us? So in 2017, I tried to answer that. So I conducted a systematic review looking at painful exercises versus pain-free exercises. And I tried to screen all of the research ever published on musculoskeletal pain, included any intervention that included some element of pain versus another intervention with no pain for any pathology, any musculoskeletal pain. And I screened about 7,500 papers. And of those, there were 7 randomized controlled trials where they compared one exercise that was painful to an exercise that was pain-free. So going back to those surveys, all those physios that had an opinion on what should or shouldn't be acceptable to the patient, it's all been derived from potentially just 7 papers that have only ever been done. And I've been keeping an eye on this, and to my knowledge, there's no new papers that have come out since this 2017. So there were 7 papers. I'm going to briefly go through those 7 papers now. So one paper looked at back pain. So they included 70 participants with back pain in Sweden. And their intervention was a high loading lifting exercise where the patient was advised that pain was acceptable up to 50 millimeters on a vase, as long as the pain subsided after each exercise. after each set of exercise. Another paper looked at lateral shoulder pain in Sweden, 97 participants. They were told to recommend 5 out of 10 for pain during the exercise, as long as the pain subsided by the next exercise session. So already you can see they're all slightly different. Another paper looking at shoulder pain in the UK, 86 participants. A single exercise that required pain during the exercise, as long as it was acceptable to the patient, as long as the pain subsided after the exercise. Then there was another one on shoulder pain in Belgium, 61 participants, that was recommended 5 out of 10 for pain, as long as the pain subsided by the following morning. Denmark, 45 participants with Achilles pain. They were told to expect pain, as long as the pain didn't increase daily or have morning stiffness. Michael's paper, looking at plantar fasciitis, they were told that pain was allowed, as long as there was no post-exercise increase in pain. And then Sweden, 40 participants with Achilles pain, they were told they were allowed up to 5 out of 10 for pain, as long as the pain subsided by the following morning with no morning stiffness. So if we think of those contextual factors, all the different parameters of how the exercise was prescribed, whether pain was allowed or recommended, if a pain scale was used or not, and the time frame for the pain to have subsided by, it didn't seem to matter. There was clinically significant improvements in all patient-reported outcome measures at all time points, and it was not clear from the data if one approach was superior to the others. It doesn't seem to matter. So then I did a meta-analysis. So I extracted all the pain data and I pulled it together and did a meta-analysis. And at short term, the meta-analysis showed that there was a small effect size in favor of painful exercises, and that was up to 3 months. And at medium term, up to 12 months, there was a medium effect size in favor of painful exercises compared to pain-free. And at long term, so 12 months and over, it didn't seem to matter. It made no difference whether the exercises were painful or not to the outcome of pain in the long term. So then I did a sensitivity analysis. So I removed some of the papers that had high risk, and I conducted a grade analysis for assessing the quality of the data. And at short term, there was a small effect size in favor of painful exercises with a moderate quality of evidence. Medium term, there was no difference of painful versus pain-free exercises with low quality of evidence. And at long term, I guess what we're all interested in, the big answer, at the long term, 12 months and over, there was no difference between painful and pain-free exercises with moderate quality of evidence. So I guess in answer to the first question, is it okay to have pain with exercise? It seems so. Certainly no reason not to. And considering that researchers ignore it, clinicians are fearful of it, and the data maybe shows that in the short term there might be a benefit and certainly no difference in the long term, maybe it's time to start to look at things a little bit differently. So can it be advantaged that the patient feel some pain when they perform an exercise? So I'm just going to start this section by just setting out my perspective on healthcare and physiotherapy for people with musculoskeletal pain. And as we're sort of demonstrating, there's a lot of uncertainty in terms of treatment. But one thing that we're pretty sure of is the health benefits of physical activity, and the link between musculoskeletal pain and physical inactivity and chronic disease is becoming increasingly understood. So for example, we know that people with musculoskeletal pain, 75% of them drastically reduce their levels of physical activity. And we know that people with musculoskeletal pain have a 17% increased risk of developing chronic disease like cardiovascular disease, cancer, diabetes, respiratory disease. And we know that physical inactivity costs in the UK, for example, 10 billion euros a year, and accounts for about 1 in 6 deaths. So if we think of those case studies, and when I often have a patient in front of me, I think, okay, they're there in front of me asking me to help them with their current pain state, their current problem. But what is going to happen to them in 5 years, 10 years, 20 years time? What am I going to say to them is going to affect them over the next 10 or 20 years with their physical activity? What am I going to say to them that is going to impact what they say to other people? How can we teach them to self-manage so that they're less reliant on healthcare? How can we encourage them to make healthy, pragmatic decisions and have a healthy, pragmatic attitude to pain and activity? And I think maybe by changing our mindset on pain and exercise, we might be able to achieve some of those things. And I think really the conceptual framework is the relationship between population level data and person-centered care, with physical activity being the link between the two. How does individual person-centered care impact on the treatment or impact on population level health? So think of those case studies: a 63-year-old male with 10 years of back pain, a 23-year-old female with lateral hip pain who's not running, and a 32-year-old female with knee pain who's been told by health professionals not to run and told to avoid weight bearing. Are we helping our patients? I guess one of the questions is, what's it really like to live with pain? And as Simon sort of started to, or has shown, it's very complex with adolescents. And I attempted to try and understand it with young adults with patellofemoral pain. And I did a qualitative interview in 2017 where I interviewed people with patellofemoral pain, tried to understand their lived experience of patellofemoral pain. So I interviewed 10 participants with a mean age of 30, 3 males, 7 females, which is pretty consistent for patellofemoral pain, with symptoms ranging from 3 months up to 16 years, with a mean duration of symptoms of 78 months. So we designed semi-structured interviews to explore the experience of living with knee pain, past healthcare management, their interpretation of causation of their pain, and beliefs and attitude to in relation to their pain, and expectations for the future. So they offered a rich and detailed account of the impact of living with their patellofemoral pain. The first theme that came from the interviews was the impact on self. So they described a sense of loss in relation to their self and self-identity. And really the future themes described how they dealt with their loss in a climate of uncertainty, and how they made sense and made decisions about their knee in relation to exercise and their coping strategies and their expectations for the future. So I won't go through all of it, but I'll summarize some of the results that might be relevant to this presentation. So they described a loss of self and a loss of self-identity with an inability to continue with significant and meaningful activities. They described how their lives were socially and environmentally restricted. I struggle at work, bending down to get to the bottom shelf and getting back up. I literally have to hold onto the table to pull myself up. I can't do it off just my knees. And then confusion and sense-making formed a central part of the lives of the participants. They were desperate for a diagnosis. They were desperate for radiological imaging. And I think for me, it's very similar to what I see in the back pain literature and the patients I see with back pain. And also those that had imaging, confusion when those images and the MRIs came back as normal. And also the third theme that came from it is around their exercise and activity beliefs. The participants identified barriers to exercise and activity, and these were related to diagnosis uncertainty, cultural beliefs around pain, with fear-avoidant behaviours and an iatrogenic effect of healthcare. So as I said at the start, are you making it worse? And that's the crux of it. I'm doing it and I'm thinking, if this is hurting, shall I really be doing this? And so that patient stopped exercising. They had confusion paralysis. The cultural beliefs around pain. With me, it's always been, if something hurt, it's because your body's telling you that if you're doing it, you're causing more harm. So they stopped exercising. This participant, I've been told by my doctor before that I shouldn't run because it will jar my knee. I shouldn't run or walk on an uneven surface because it will wonk my knee from side to side. So we have a young female here that's now been told by her doctor that she shouldn't run or walk on uneven surfaces. So a central coping strategy for the participants was the concept of rest, so avoidance and rest. I try and sit down as much as I can. This participant was asked, what would the physio say about remaining active and doing some exercise? The physios would say, no, you shouldn't do it. And they had low expectations for the future, which could be conceptualized as low self-efficacy, belief that their pain will get worse, with poor opinion of physiotherapy. The pain is preying on my mind. Is it going to stop me from going into the police? Is it going to stop me from doing the things I want to do later in life? It does prey on my mind a little bit. This participant was asked, have you got any expectations of what might happen when you walk in to see the physio? I expect them to turn around and say that physio can't help them or can't help me. And this participant said, when I'm going up the stairs and it hurts, it does concern me that it's going to be every day for the rest of my life. I'm going to be struggling to walk upstairs. And then I think about getting old. Am I going to end up with a stair lift, living downstairs, that sort of thing? That's a 26-year-old female. So I guess the take-home messages from that interview is that there's cultural beliefs around pain and exercise. There's pain-related fear. There's an iatrogenic effect of healthcare, and it all limits their exercise and physical activity. So is there anything else we need to consider? Well, if we read up on the pain literature, we know that contemporary models of pain reconceptualize pain and put forward concepts that are based on the premise that pain does not provide a measure of the state of the tissue, and it can be modulated by many factors, and the relationship between pain and tissue becomes less predictable the longer pain persists. So altered central processing to the way that people process pain has been shown to be present in many pain conditions. The immune system has been shown to play a role, and pain-related fear has been shown to play a role in the presentation of pain. So unhelpful thoughts from the patients and the clinicians, with fear of movement and low self-efficacy. So the idea that that exercise and movement will cause more injury and more damage. So for example, this systematic review looked at self-management interventions for people with musculoskeletal pain, and they were trying to identify programs that promoted self-management and what works and for who. They included 16 studies with 4,000 participants. And they found that the strongest prognostic factors were around self-efficacy and depression. So the things that predicted whether people got better was self-efficacy, so whether they thought they'd get better, irrespective of what the intervention was, or if I was being facetious, I might say despite what the intervention was. And the strongest mediating factor, so that is the things that might explain how an intervention works, were catastrophizing and physical activity. So improving people's fear of moving and exercise and worrying about the future, and generally getting people more physically active, seem to be the factors that mediated people getting better. So maybe we need to prescribe our exercises based on these mechanisms rather than maybe ones that we traditionally do. So self-efficacy, for example, so the ability to cope, your belief in your capacity to successfully complete a task. My perspective is that exercises, and particularly exercises that have an element of pain, can help facilitate self-efficacy. So two of the main elements of self-efficacy is the response outcome. So the response outcome being the likely, or the belief in a likely outcome. So if a patient is doing an exercise, do they believe that that exercise is going to help them? And then the efficacy expectation. So do they believe that they can actually do the exercise? Can they do the exercise? Is the exercise going to help them? And my perspective is that by having goals and having challenging patients where the exercise is painful, that we can actually facilitate and enhance their self-efficacy. So for example, this schematic was adapted from Louis Gifford's paper. And for me, it summarizes how exercise can challenge some of those factors that I've mentioned, the central pain processing, the immune response, the patient scrutinizing what that pain means, past experience, knowledge, beliefs, reconceptualizing pain from something that should be avoided to something that can be okay, start to challenge those traditional exercise prescription models and challenge the patient. So how might we implement that in a patient-centered biopsychosocial approach in a busy clinical workday? So my PhD, I developed an intervention called the Cognitive Approach to Physiotherapy for Patellofemoral Pain, or the kneecap intervention. So the kneecap intervention for people with kneecap pain. Now, I didn't come up with this name. A colleague of mine came up with it, so it means I'm allowed to say that I think it's brilliant. But essentially, I followed the MRC framework for developing an intervention, and it was about a 4 or 5 year project. And I'm up to about phase 2 of that process. And a biopsychosocial framework, really it's about effective communication, providing an explanation that makes sense to the patient, creating a safe therapeutic environment, facilitating self-care and individualized care, respect cultural differences, foster resilience and coping skills, and expose or challenge their behavior and beliefs through exposure to activity and exercise. But to summarize that even further, the 3 main domains is around pain education, exercise, and self-management strategies. So pain education, so to address beliefs that fear is a sign of tissue damage, descriptions of tissue pathology models, actively discourage and challenge, trying to facilitate pain and reconceptualize pain from something to be avoided and fearful of. Exercise, so deliver an exercise that challenges the patient, that gradually exposes them to the things they find painful and fearful, with 2 main variables, pain during the exercise and pain after the exercise. So the patient is taught to self-dose and self-titrate so that the pain is acceptable to them while they perform the exercise, and the pain is acceptable to them after the exercise, and as long as it settles relatively quickly. And the patient is taught to self-titrate and to self-dose their exercise. And then self-management strategies, so goal setting, managing flare-ups, talking about barriers to success, self-directed exercises, but really using the exercise and the education and the self-management discussion to facilitate how the patient can use those strategies in their everyday life. So the activities and the exercise and the physical activity that they perform in their life, how can they use those strategies to help with that? So a typical session might be review their exercises, review adherence, discussion, a conversation with the patient. Talk about their sport and their exercise progress, discuss any barriers, any problems they've had. Review their exercise performance, go through their exercises, progress if appropriate, or regress if needs be. Set new goals and schedule a review appointment or aim for discharge. So lots more talking, a lot less hands-on. So we'll go back to those case studies. Now, we haven't got time for me to sort of say what I did with those patients, but thinking about those strategies and how we might use those strategies with this patient. So case study of neck pain, 63-year-old male with a 10-year history of neck pain, owning a treadmill. Really that biopsychosocial framework was about addressing his belief around pain and exercise and the treadmill, and really using that treadmill as a really good exercise and goal-orientated rehab program, but using the pain as the measure of his exercise dose and teaching the patient how to dose his exercise. So this high-level athlete with lateral hip pain, her rehab was sprinting. So I taught her that, yes, carry on with the gym work, carry on with all the exercises that she found useful, but her main rehab was sprinting. So she was taught to self-titrate her running and her sprinting, to gradually push and build up and expose her to the thing that she finds painful and that she's been avoiding. And then the patient with patellofemoral pain with an osteochondral defect. So the same thing, gradually skip slide, gradually exposing her to running, to weight bearing, and exposing her knee to the stresses and the strains that she's been avoiding, and gradually working with her behavior and her beliefs around pain and what that means, and working with her on goals with running to build her up. I mean, I will briefly summarize this patient. So I saw her when she wasn't running at all and hadn't run for probably 18 months. And it really took 2 to 3 years to get her up to marathon level distance. She wanted to run marathons. So it's a good example of prognosis and timeframes, that she could get up to marathon level distance, pain-free, but over 2 or 3 years. And I still see this patient on and off. She wants to try and run ultra marathons. She finds that when she runs ultra marathons, that flares her knee up. But she went from a stage of being told not to run and being told to avoid weight bearing to being able to run marathons. I'll summarize now. So limitations. So the work I've talked about is really in the concept stage. Done. So, for example, here are some quotations from some of the participants, and it was specifically around what they thought around exercises that were painful, what they thought about the element of pain and exercise. So one participant said it was empowering. So actually encouraging them to do something that was painful, they said it was empowering. One said, when I hit the target, I thought, oh, actually, I can actually do a few more, and it is comfortable. Another one said that sense of just how much progress you made. And another one, I think, summarized it quite well. It's that change in mindset that says, I can still do these things. I'm not shying away from getting stuck in and being active. So I think really, maybe for discussion or something to know, I think it's really interesting to know what we do with non-responders in general with physiotherapy. I think questions and debates that I have in my head that I don't necessarily have answers to, but how do we deal with non-responders? What is appropriate versus inappropriate escalation of care? How do we use our assessment and treatment to help with prognosis? What is the ultimate balance between physical activity levels and levels of pain? I think they're really interesting debates to have, and that's my talk. Happy to take questions and get in touch if anybody wants to. Thanks very much for listening.
Thank you, Ben. I have a question to start it off. You talked about challenging beliefs and encouraging physical activity, maybe even with pain. And I would like you to expand a bit on how you go about that. As like, would you go more in an exercise direction to like challenge them in a physical way and make them experience that this is okay, or is it more of a talk thing, or both, or how do you like differ, or how you understand?
Yeah, so it's a great question, and I think without giving an answer that everyone does, it depends on the patient, but generally I would probably have a discussion with the patient. And I guess this goes on really from my question to Simon earlier about actually what the patient defined as successful or unsuccessful, because the qualitative work that I've done shows that the patients will say, oh, I can't run because of the pain, or I can't do something because of the pain. And then so my immediate question is, why? And they often look at me like I'm crazy. Well, because of the pain. And I say, yeah, but why? What happens? And then I'll often try and break it down and say, is it that the thing you're talking about, and it's not always running, but let's use running as an example. If you were to run, the pain that you were experiencing, is it more than you can cope with? Or if I asked you whether you could cope with it and force yourself to do it, could you do it? And often I find probably 9 out of 10, the patient usually says, oh yeah, I could cope with it if I wanted to. I just think I shouldn't do that thing that's painful, or I've been told to avoid it, or in my mind, I'm worried that I make the injury worse. So therefore I'm avoiding those things because of the belief and because of my attitude to what pain means, rather than the actual level of pain they're in. if what they're doing, the pain is more than they can cope with, well, then you can have a question and you can have a discussion around dealing with flare-ups. And you know, the criticism I often get is that I tell patients to just go and do things that are painful and just run a marathon and just ignore it and get on with it. But it's not about that. It's about sort of trying to, as I say, self-titrate. And the example I often give to patients is the Goldilocks story about the porridge, and the porridge that's too cold and the porridge that's too hot. And if they avoid all the exercises, then the porridge is too cold and they're not going to get any benefit. If they go crazy and do too much, I say, well, you know, you're not going to do any damage. You know, don't panic, but you're probably choosing porridge that's too hot, and in the long run, maybe you won't get the benefit. We have to find that porridge that's just right, that will be a bit hot, so a bit painful, but not too hot and not too painful that you can't cope with it. So that's usually how I sort of start the discussion.
Thank you. There's a question, but I'm not quite sure I understand it. Fatima, she's asking, you talked something about 7 papers. Is this 7 interventions or pain experiences in different countries? Or I'm guessing she's asking back to your review.
Oh yeah. So so that was a systematic review where I tried to look at all the trials that have ever been done, comparing a painful exercises versus a pain-free, and there were 7 trials that I could find and that I included in the review that compared a painful exercise to a pain-free exercise.
I guess that's all the questions for now. Maybe the interruption has an influence. Oh, we have another one now. What if they end up pushing too hard and end up getting an acute injury?
Yep. So that's a question I get asked all the time. So again, I think of the Goldilocks story, but I think if we think of that Goldilocks story and we put our scientific head on it, then I think that we have type 1 errors and type 2 errors. We're worried about overdosing our patients, and we compensate for overdosing our patients by underdosing the majority of our patients. So we can all think of that one patient that we asked them to do something, an exercise or an activity, and they came back to see us 2 weeks later in agony, where they'd been in pain for 2 weeks. They didn't want to speak to me. They were putting a complaint, you know, they were angry with me. They, you know, and we can all remember that one patient. And because that one patient and that type 1 error of overdosing somebody, then we underdose everybody else. The problem with the underdosing is we don't get that immediate feedback of a patient being angry with us. We just get years later of knowing that we haven't given them enough exercise and they're maybe not doing enough that they should be. So yeah, there's always a risk that somebody will go out and go crazy and do something more than they should do. But I mean, I think that's why I talk about the idea of teaching people to deal with flare-ups, teaching people to self-manage. It is trial and error, particularly the first time they try something. It's a bit of a guess about how much to do. You know, when I see people with long-term persistent back pain, and we talk about walking or swimming or running, I talk about people swimming one length. So that's, you know, that's often what we start at, one length. Or walking, that chap on the treadmill, we were talking of seconds. So getting on the treadmill and managing 10 seconds, 20 seconds, and teaching him to go from there. And I think, yeah, I think it's just teaching the patient how to self-dose and to self-deal with the flare-ups. So it's putting the emphasis on the patient being in charge, not the physio telling them to do 10 reps of this exercise. The patient decides.
I think we'll go to Morten's presentation or first, and then the rest of the questions we'll get back to when we have like an end discussion, just so we don't run out of time. So I'll give the word over to Lærke.
Yes, og vi må jo lige op på hesten igen her, og nu er det tid til den tredje og sidste foredragsholder, der er Morten Høgh. Og Morten, Michael, nu vil du lige rette mig, hvis du ikke er enig, men jeg tænker, vi måske bare lidt kørt over i plenumdiskussionen sammen med Morten nu, og ellers så ændrer du bare den påstand. Men for lige at præsentere Morten Høgh først, så er Morten jo assistant professor ved Aalborg Universitet, hvor han har taget en Ph.D. lavet en Ph.D. om smertevidenskab. Og udover at forske og formidle den her forskning gennem både publikationer og undervisning nationalt og internationalt, Morten stadigvæk fingrene i
Du falder ud, Lærke.
Jeg er bange for, det var mig.
Jeg falder ud?
Ja.
Okay, jeg får at vide, at min internetforbindelse er ustabil.
Man kan godt høre dig igen nu.
Ja.
Man kan godt høre mig. Okay. Så jeg ved ikke, hvor meget I fik fat i, men Morten han vil i hvert fald tage over her med et oplæg, der er lidt anderledes i setupet i forhold til de to andre. Det er ikke noget slideshow i den forstand, men mere som en plenumdiskussion, og hvor essens ligesom bliver, at vi skal tage udgangspunkt i det, vi har på hjertet, både hvis vi har spørgsmål i relation fra de to andre oplæg, eller bare til Morten i sig selv i forbindelse med alt det, vi har snakket om i dag. Så nu handler det om at byde ind på chatten, og så lade det handle om det, vi ligesom selv synes er svært derude. Så velkommen til, Morten.
Tak. And with regards to Ben, and also to include him in the discussion, I'll be presenting in English, but questions are obviously welcome in Danish, and we'll just translate as we go. So when we started planning on this, I think the question that Lærke posed to me was, would you say something, because we want to know more about this painy thing, which I of course adore. I like to talk about it, so that's great for me. And it started out with students from Aalborg University doing the MSK in physiotherapy there, the master's program. And I think, if I'm reflecting on it, why would you ask me? I think probably what most students would do is feel a bit insecure, at least about exams. What do I need to know in terms of exams, but also what do I need to know in order to become a better clinician? I assume there would be some aspects of also wanting to have that certain knowledge, of wanting to know something for sure. Definitely if you expand your knowledge, if you attend courses, that's probably one of the things that we want to know the most, is just like the questions here: how do we do this, how do we do that? So we want that certainty of knowledge, and most definitely also with the students I encompass, they are very eager to learn. So for most students, knowledge itself carries value. And I use that introduction because I want to bring that as a path, or as a bridge over to talking about patients. I also think that when patients come into our place, so the first sort of question I was asked is, how do we communicate pain understanding, or how do we facilitate behavioral change? And I think patients, just like students, they feel insecure. There's definitely stuff they would love to know about, but maybe not so much the intellectual knowledge-based stuff, probably more quite factual stuff, like what do I do, what can you do, this sort of very, very simple stuff, because most, unlike students, I would assume, the majority of patients who come into the clinic, they don't feel they need any knowledge, and most definitely don't think that knowledge itself carries any value. There's been a tendency, at least in physiotherapy, to believe that simply knowing what pain biology is would have a pain reducing effect. I think most people would now realize that that cannot be true. But definitely there's been some advantages in how we deal with pain that we have come to understand over the last 20 or so years. But what they really are, the value of them, is something that we could discuss. Okay, that was not for me. So, as I said, patients, they don't seek knowledge the same way that students do. I think that's because they don't know, if you understand what I'm saying. So if you're a student, you probably are able to create some sort of question that you want an answer to. What I think we're bad at, what we're not doing well enough, is probably asking ourselves, why do we want to know that? So more precisely, what is the problem that we're trying to solve? And I would like to reverse this session now, that everyone who is listening, I would like for you to sort of present to us what are the problems that you would like solved. And think of it as in the clinical setting. If I say to a patient with a 5-year history of chronic pain, why are you here? What problem can I do for you? The majority would say, I would like the pain to go away. So rather than simply saying the obvious, in the case of the patient, maybe it would be ideal, but it might not be realistic. So the equivalent here would be to say, I want to know everything there is to know. I assume that would be ideal, but that's not realistic. So what is it really that you want to know? And I see Simon has a comment on that. I invite Ben also to share a comment on that. And I know that this is definitely something that we would, from Aalborg University, love to take in and to use for further research. So I would invite everyone to share back with us. What is it? So what is the problem with anything pain that you would like to solve here now, or as soon as possible? What's the biggest obstacle in your knowledge gap or whatever relation to pain? If Ben and Michael and Simon wants to share any ideas, please do so. Otherwise, I'm just waiting for someone to take over the chat.
Maybe I can then start by, because based on what you said in the beginning, Morten, you're talking about knowledge. Simon is also talking a lot about the experiences we have. And it just makes me like reflect on what is it that is important for the patient to start to take ownership or become ready in some way? Is it the knowledge component, or is it the experience component, or can one be without the other? And what should we do?
Yeah.
I would love to hear all your perspectives on that. Not that I have the answer, but your take on this, all three of you.
Well, I'm happy to start and just let it go from there. So I think what increasingly interests me is what drives people. Why do they do this? Simon was talking about how they explain stuff. I think that's really interesting. I'm really interested in knowing what is it that people, how do they explain it first of all, but why do they want to change? What is it they would want to change? And then second, is that possible? Is that viable? Is that the most likely solution? Is that something we can deal with? Because I think we take patients into therapy without realizing whether or not we are actually capable of helping them.
If I can chime in on this discussion, because I before we are getting too many interesting points raised all at once. First and foremost, the reason why I decided to chime in was because I think you raised a very interesting point where you were talking about the concept of knowledge and what maybe patients don't know. How can you say, maybe they don't know that they have a need to know. And one of my favorite papers is Strauss and Corbin's 3 Lines of Self-Management, really old paper from, I think it's back in the 70s or early 80s when they're talking about self-management and how they're like these three lines. And I think this is they've both said this, but also Moen and Brennan, they're talking about how when you enter into treatment in a treatment situation as a patient, this opens up a lot of different challenges. So you're looking at different knowledge situations that are occurring, where the clinician will give you knowledge on, your condition and what do you need to do, but the challenges that the patients face are multiple and very different, and it's more like related to how do I integrate this knowledge, how do I understand this in relation to all the other things that I am experiencing in this area. So I think that when we are talking about knowledge, we might have to recognize that we are talking about different types of knowledge that are needed. Maybe they're the same, but there is sort of like a transformation that occurs outside the clinic. And I think one of the major things that I think could be really interested in looking into when we're talking about what we would like to look into is to look at how the knowledge that is given in clinic, how it actually transforms and becomes something different. And also with treatments, how do they actually contribute to the development outside? And in order for just to answer the other question that you were talking about, what is it that makes patients change? I think that when we're looking at self-management and behavioral change in general, first and foremost, I'm not a big fan of behavioral change myself. I've worked with persuasive design for some time, and I see the faults of it as well. I more like to address it as work, as a continuous work process that goes on. So how can we make patients able to work towards betterment? Because behavioral change is sort of like, we'll change one thing and then we've solved all the rest. And that's one of the things. But I think that looking at self-management as more of a thing where, how can you say, where instead of just managing the condition, you're managing many things at the same time. Maybe that could also be another point for understanding this and becoming better at facilitating this change.
There's a lot of things I want to say on that. I wanted to maybe, in the interest of time, it would be wonderful if we could focus on what physios want. I think what we tend to do is we tend to give webinars like these, and then we tell them stuff, like we would teach anatomy, or we would teach methods, or this is how we do it. I think there's too little room where people can actually say what they want to know, and then we try to evolve from there. So while I really encourage to go that way as you describe, Simon, then what would be wonderful here with so many people in the audience would be to know what are the problems they're struggling with, not just in terms of headlines or popular ideas, but what are really their individual problems. And I think there would be some common themes in those that might be interesting for the future work of our research group.
I've got a few if you're ready, Morten.
Absolutely.
Well, so I think your question is brilliant. The fact that patients say, "I want my pain to go," then my first question as a clinician and as a researcher is, how do we deal with that question? How do we answer that question to the patient? How do we tell them that that's not realistic? Because I think if we go along with it and sort of make them think that we can help their pain, then maybe we're not being entirely honest. Or how can we tell them without immediately disengaging them from physio? Then when you've done that, you're talking to them and you want to reassure them that there's nothing serious going on. And then the first question they ask is, well, why, if there's nothing serious going on, why am I in pain?
Yeah.
Or if they've had a scan and the scan's okay, or, and you try and talk to them about, asymptomatic scans and what a scan would look like in someone without pain, and you try and reassure them that the findings are normal, and you try and reassure them that your assessment shows that there's nothing to worry about. Why am I in pain? So then how do we answer that? And then we'll treat people, And invariably we get about 50% at a stage where they're happy with their symptoms. And that's pretty much across the board. So research, RCTs show 50% in most pathologies, and most audits that I've read, 50%. If we include slightly better on a sort of a Likert scale, then it sort of jumps up to about 70%. So if we sort of make ourselves feel better and include patients that think they're slightly better, then 70%, and so that makes me feel better. But then what do we do with the rest? What do we do with those non-responders? How do we essentially discharge them from our service, being no different from when we saw them at the start? How do we deal with those non-responders? Because I think there's a lot of physios that will bounce them back to primary care and say, well, the GP will go and deal with this. Or they'll escalate it and send them for a scan, and then you've got to deal with that. Or they'll escalate it and send to an orthopedic surgeon. And, I often have chats with students and I say, well, that patient that hasn't got better, they're your patient. Take ownership, take charge, and deal with the situation, and deal with the fact they're a non-responder, so that you don't escalate it and make more of a problem. So those are my 3 questions.
Well, they're easy ones, aren't they? But I guess it would be wonderful to start out with a question I think everyone has, or the problem everyone has in the clinic, at least in the beginning, is as you say, well, if you ask a patient, what can I do for you? And the patient would most likely say, make my pain go away. And then how do we deal with that? And I think what you alluded to, and what most clinicians would do if they're sort of trained in this area of expertise, then they would probably use techniques from communication and perhaps some sort of motivation interviewing, rather than giving an explanation right away, wouldn't they? So I think that's definitely part of the answer here, is to understand that we have multiple capacities, and also we need to be confident with a variety of techniques that go way beyond manual therapy and exercise therapy, for that sake. And even starting at that level and thinking, this is my first bit of therapy with this patient, might be what actually makes us succeed in the other end, where you need that exercise physiology, for instance. But if you can't create the basis, at least, of a therapeutic alliance with your patient, is it likely that there's going to be any sort of knowledge transfer, behavioral change, whatever you call it, at any point in that part? So I think the easy question, or the easy answer, would be, it's all about communication and creating a good therapeutic environment. Now how to do that, of course, is much more complicated. But what do you think about that?
I would like to comment on that, because as a student right now, I can tell you that is almost nothing of the all education that we have as a physiotherapist. So please do more for that. Yeah,
but how do you go about that? I mean, adding it to a curriculum is quite tough. Changing curricula is quite tough, and it seems to be something that people, just learn. Whereas what we know is that we just don't learn it. We seem to learn it from each other. So if we don't add it to the school, if we don't add it to the curriculum, we will have massive problems over time as it gets more and more prominent. And I think, just to speak of the problem that we carry along with it, is that if we keep solving problems linearly, so we look for something to change in order for the patient to become better, we never get to step out of a role of the almighty and into the role of a collaborative expert who shares expertise and provides agency to the patient. But what do you guys think?
If I could chime in one more time. Just in relation to the question that you had on how to engage with the patient who says, that they want you to just simply remove the pain. So some of the things that I've heard, especially with my workshops and all that, that's the first question. And I think that as Ben already sort of made us aware of during his presentation, that sometimes you need to go beyond that as well. and talk about, so, okay, why is it that you want the pain to go away, and what is it you want to achieve? And then sort of move the conversation more towards, if the pain doesn't go away, or if we can reduce the pain a little bit, what is it you'll then be able to do? And can we find an alternative for how to do these things, so that you sort of get the ball rolling and you get them into another lane of thinking, where you will see small changes in behavior and then small changes in perception as well. Because I think that one of the key things here is to remember that even though this is not really that well understood in literature, there is sort of like a connection between behavioral choices and then perception as well. So get the ball rolling a little bit on the behavior, and then maybe change the, how can you say, change the perspectives as well. And also another thing that we're looking into, especially when it comes with the adolescents, is this understanding of identity and personal connection to others as a way, as sort of like a pull for changing behavior as well. So talk about, okay, how can you get back to your sports or something like that, as a way of circumventing the pain, make the problem smaller with the pain as well. And I think Michael's tool, the load management tool, does that quite well.
That probably ties pretty well into Jonas's question: how do we go about reconceptualizing the self with pain without forcing that goal onto the patient? So in my terminology, what I think of is trying to avoid this non-linear approach. So if we treat pain the same way as we would treat a wound or bacteria or even a virus, then I think we're doing something wrong, at least when it's chronic pain, because we simply don't know. I mean, the way we deal with chronic pain, with coronavirus right now, is probably more how we would deal with chronic pain compared to what we aim to do when we get a vaccination, right? So the things that I've written down here would be partnering with the patient, making sense of the pain and the disabilities. So making them not necessarily understandable, not necessarily always predictable, but at least making sense of them in some sort of qualitative way. And then I think what my patients at least seem to really enjoy is that planning and predicting. So they have an ability to plan and predict their lives, not necessarily without pain, but knowing what will lead to more pain or less pain. Just like you said with the exercises, Ben, and your quotes from the patients, that feeling of having agency over your pain, I think is quite important. And I think the way to stimulate that would be to embrace the patient as an expert.
I find I am constantly debating these issues in my head, because I go from 1 minute, I'd be interested to see what you all think. On 1 minute, on one hand, we often hear the phrase that we shouldn't let the pain dictate what we do, and shouldn't let the pain dictate our levels of activity. And then so I hear that and I think, yeah, I agree with that. Yeah, that sounds sensible. That sounds like a good way forward. But then I think sometimes pain is a really good way of teaching people to dose their levels of activity, to learn what is what their baseline capacity is, and to slowly build from there. So then on one hand, then I think, well, actually we can use pain as the feedback, and actually use pain to decide exactly, or teach the patient to decide exactly how much exercise to do. And I often, flip between the two, and I think, I went on Peter O'Sullivan's workshop last year, and I saw so many similarities in sort of his CFT intervention and the intervention that I developed for patellofemoral pain. And again, we end up with two different kind of scenarios. You end up with, so we want to, if we make it really simple, we've got somebody with back pain, and it hurts for them to bend, and they're fearful to bend, and we want to help them to do that. And I think we end up again, with an argument, with a debate. So some people think we should be able to try and get like an in-session change. So we should be able to instantly teach them to relax and to reconceptualize pain and to be able to do something. Or do we say, actually, we can't get a quick in-session change. We need something to be slowly adaptable over a long period of time. And I think the analogy I often use, and I'll stop talking in a second, and maybe this doesn't work for anyone, but my analogy is it's similar to people that are fearful of spiders. I think we often hear stories of somebody being really scared of spiders, and they go to some circus, and somebody dares them, and they put a tarantula on their hand, and they get an instant, almost magical recovery from being scared of spiders. Or another approach is they'll put a small spider in a jar and put it next to their desk, and every week they'll change that, or they'll get somebody else to change that spider for a big spider until they slowly over time acclimatize. And I don't know which one's best.
Well, first of all, Ben, I think the spider analogy is great. That's how Flane and Linton developed their fear avoidance beliefs approach, wasn't it? So that, sorry, the what's it called? The fear avoidance model.
But patients don't like that analogy, I've learned.
Oh, that's actually where it came from. So that's arachnophobia. But I think coming back to your two sort of dilemmas, or I would say dimensions. So on one hand, you could say, well, pain shouldn't dictate whatever you do. I think that's a really arrogant approach. And I think I know I have it as well. But what I think we should increasingly try to do is to understand that it's not our prerogative. It is the patient who has the pain, and it should be them who says, it's all right with me, or it isn't. And that sort of brings me to the other version, or the other dimension, which is if the patient don't mind having that pain, or if that pain might even, make them feel more sufficient, or doing something that's good for them, or giving them agency, I'm full into it. Because I think as long as we're dealing with chronic pain, and as you alluded to in the question you got, I don't think that chances are that they will hurt themselves. I mean, we don't have any suggestions that people with chronic MSK problems don't have a functioning nociceptive system. So the chances are that they won't go hurt themselves if they restrict themselves within the same boundaries as anyone in their condition would do. So I'm not so afraid of that, as long as the pain is meaningful for them. So if they can answer the why question, why would you want to bend if it hurts? Say, because I don't want to not bend, but go ahead. Whereas if they can't answer that, or if they say, I really don't want to bend, but my physio told me I have to, I would say, well, why would you want to do what your physio says? So I definitely identify both of the dimensions, and I would like to put an emphasis on the latter, and say I think it's great if we could have a bit more interest in acknowledging the patient to be the expert. Why would you want to do that? I need to understand as a therapist, why would you or wouldn't you want to do that? Because that's so important for me to advise you. But I don't know what you guys, what do you, Simon, what do you think?
Well, first of all, if I could chime into this, I really agree with what you're saying right there. And just to expand on this context, I mean, I had to remove one of my slides from my presentation, but this is a slide that I've used a couple of times, where I sort of talk about patient education and how patient education and the way that we look at this is still very much back in how our public school was when we were back in the 40s, and how we do education of kids today as more as a way of teaching people how to learn instead. So they are not just learning things, they're learning how to learn. And I think that especially looking at the collaboration between the clinician and the patient, that is alpha and omega to avoid this linear approach to educating. I mean, acknowledging that this is a collaboration that might run over several consultations and maybe even over a very long period of time, is one part. But I also think another part that we forget to mention is maybe we also have a little bit of a linear look or view on pain. You could correct me if I'm wrong here. When we see pain, we see it as one thing, but maybe we also need to see that as an evolving concept, at least in the way of how the patients see it. We start out with seeing pain as just a bad thing, but maybe it becomes, as you mentioned, some pain is acceptable, some pain is not acceptable, and having that exploration as well into it.
Well, I think that that aligns very well with looking for. Magnus had a comment regarding the incorporation of the VAS scales, the pain intensity scales. Are they redundant? And I usually, when I get that question, I think that's a really good question as well. When I get it, I would say, well, if for me, NRS or VAS or whatever are simply communication tools. So they're metaphors to explain how intense the pain is, or whatever you put on the, the end of the dichotomies. So if it works, if you're really communicating meaningfully with that scale, so that, for instance, I have 7 out of 10, knowing we both have a sort of understanding of the ends of that, the 0 and the 10, and then I do whatever, or the patient does whatever, and that number changes, and the number is a good explanation or a good metaphor to understand what goes on with the patient, I think it's good. But to the extent that we use it to either understand or change, or I know that Ben, you and others have used VAS scales to sort of communicate to patients how much pain are you supposed to be in. I think that's, in my mind, that's sort of what we are going less and less into, what I would suggest, because we don't know how they would interpret that pain, would it? So unless we know the why question, the answer to the why question, how does 7 relate to your feeling confident doing this exercise? If we don't know that, I wouldn't feel comfortable just over an email writing to a patient, well, 5 out of 10 is fine. But I mean, the more we know them, the better we communicate, the better that tool might actually be. But as a generic pain communication tool, I'm not sure it's better than anything else we have, but it's quite simple.
Yeah, I mean, I agree. I agree it's a good tool. I've not been a huge fan of it in terms of dictating to whether a patient does or doesn't continue with their exercises, or in terms of dosing exercise. Phrase I've heard, I think Chris Littlewood said it first. Is it potentially could be fear avoidance by stealth? Because you say, well, 5 out of 10 is okay, and 6 out of 10 suddenly isn't. Well, what happens at 6 out of 10? What happens if they're halfway around their run? What happens?
Yeah.
And then they're they're running the whole time, or I say use running as an example, but thinking, is that a 5? Is it a 6?
Yeah.
What happens to the people with base level of pain at 6? Can they not exercise? I think, my view is, I think it's fear avoidance, and almost biomedical orientated by nature.
Yeah. Oh, I completely agree. It's almost as if we planned on saying this, because Pernille has just put in a comment that Trina has put in earlier, which is, couldn't pain period be a diagnosis? That's something I would say. It is, as a matter of fact, it is something I say. So I think pain is a good explanation for why you're here, but that doesn't follow up with any specific treatment. I think that's the thing we need to come across, is that you cannot say that there is a specific treatment for any specific experience or sensation. So if we can just separate the two and have a good chat about being in pain and what it means to you, and what can you do about it, what does it make you want to do that you can't do, whatever, and separate that from whatever treatment you need. So that's what I call pain, period. I think that's where we should go, and have that, decent and respectful discussion with our patients. Is there anything beyond that pain that needs our attention, that we can actually be therapeutic or interventional towards?
I like this debate about using pain scales, because I've also been using these pain scales. So So I think I dropped out for a second there. I think everybody's back again. No, it's just a comment
we hear you.
On the pain scale, that in some way, because I have been using it, we've been putting numbers from 3 is the limit, where it's below 3 is okay, and above that is not okay. But our original aim with doing so was that when we interviewed patients about developing something they could actually, that was tangible to them, they wanted some like fixed things about when is it okay, when is it not okay. So we wanted to make it simple. That was like the basis for doing it. But now when I look at it, I can also see that patients actually become fear avoidant, exactly as you say, because my baseline is a 4, so I shouldn't move, right? And it's like they want something, and then when we try and develop it, it actually have some side effects in some way. I like the idea with both you and Morten, so Ben and Morten, says about understanding the patient, maybe using words to articulate it instead of trying to put fixed numbers on when is it okay, when is it not okay. I think, Ben, you've earlier used like tolerable pain as an example of a word you could use, because then we make it fit our patient because it's tolerable to them.
And I think so. The Likert scales are widely used for good reason. That idea of taking something really complex and dichotomizing it. So there's a good and a bad. There's a 0 and a 10, whatever. So we have the patient-specific functional scale as a good example, where you find something that's relevant for the patient, and you have 10, which is what they're used to be able to do, and 0 is if they can't do it at all. And then you have this, the numbers are a way to communicate how far are you from being able to do it, where we know that, the verbal rating scale is really not, it doesn't work that well. So maybe verbally it's difficult. And I think we carry a lot of weight with us when we want to use clinical experience for research purposes as well, because in research we need those quantifiable boxing of things. Well, I don't know if we do that, but the way I understand most science, I think we do to a degree. And as long as we know the barriers of that and the limitations of it, I don't see a problem with it. But there's a difference from that and then encouraging the blind use of Likert scales in the clinic, which I think most people nowadays would not do. So Henrik has put in a comment here. Henrik, do you want to unmute yourself and comment on it? I don't know. I'll just read out his comment. No data suggests that we should recommend avoiding pain, but also not better to exercise with pain than exercises without pain. So if non-painful exercises facilitate physical activity, they may be more useful, but pain during activity can be the primary barrier for being physically active for patients with chronic pain. So I guess it doesn't have to hurt, but if it does, it's okay. That's Henrik. So those of you who may not be familiar with Henrik, this is also his very specific area of expertise. So he's a world-known expert on the field. So I don't know if anybody would like to disagree with him, but I see it as if he agrees with us.
Well, I'll jump in. I think this is another one of those ones where I chop and change my mind, I'm afraid. So one day I'll completely agree with that, and I'll think, yeah, that's where I am. It doesn't have to be painful. But then some days I think it should be. I think there's something intrinsically beneficial about somebody in pain, where they're doing a rehab exercise or some physical activity that they find painful, and there's something it's sort of fundamental to the rehab process that it has to be painful. So I'm half and half. I think at the moment, I think there's a bit of me that thinks it does have to be painful. Now, in terms of how painful that is, the patient's in charge. It can be whatever, absolutely mildest of mild pain that they they're happy to tolerate, and when they finish the exercise, it settles at a level that they find tolerable. It doesn't have to be, you know, excruciating levels of pain, but there's something about that process that I think it has to be painful.
But don't you think
no, go ahead, Mike. Yeah.
Don't you think, Ben, that it also depends on how we frame it when we're with the patient, that is the key thing? At least that is my way of thinking now, after been working with you, that I actually think pain is good because we create a learning situation. We get to talk about pain, we get to talk about what it is not and what it is. And there, pain during exercise is a nice learning situation for that. But if it just was like pain on its own, but we wouldn't harness the power of that learning situation, then I would go with trying to avoid pain, I think. Or not necessarily using it.
I'm burning up with my comment here, because I think this is.
I've got one as well.
Yeah, but you know what? This is probably where I think we're biased, because we've done some research. Because if we were talking about one patient at a time, we wouldn't have this discussion, would we? If we would just ask the patient, how's this? And is it all right with you? Do you feel comfortable? Is this good for you? And they would say, no, I don't want to be in pain at all. And you would be doing something that's not painful. So when it comes to preference, of course, we all have different preferences. And we now know that, Ben, you like it a bit rough. But that's a personal preference. And when it comes to patients, that's the same thing, isn't it? We just need to understand that they have preferences as well. So I really love this space between research and the clinic, and I'm not sure when to stand on one leg and the other, but I really love that sort of switching between them, because it makes everything much more complex. And I feel great in that room.
I can just chime into this one. First of all, I agree with you one more time. And I think especially this is not something that you cannot, there's not like a one size fits all with this. But in generally, and both from what I can see from my research, and as well as the literature that I've consulted throughout my career within looking into this, I think that in general, this understanding of one more time to, what can you say, also to pressure yourself and to find out how far can you take it into the pain is actually extremely central for learning how to manage as well. And therefore I would definitely say that excluding pain completely from how can you say, from exercises, in my best opinion, that would be a mistake, because you're taking away the chances of exerting control over the injury, and also this with the idea of expanding the locus of control, because the only way you get control over your pain is by being in it and getting, like the understanding and finding out what are the performance indicators. When can I perform and when shouldn't I? So
I guess
my opinion is correct.
Yeah, if we were talking about someone go to the gym, we would probably encourage them to do enough to feel uncomfortable at least. So in the lower end of the VAS scale, and I think that's part of life, isn't it? Is being in that situation where things are uncomfortable at times. And if you ask someone who is an athlete or a soldier or someone like that, they would have to be comfortable in working in that uncomfortable, or sensually uncomfortable zone. But I guess the reason we're going so much about this is because the patients we talk to here are specifically going about pain as a problem. So I guess maybe what we could discuss, that probably be a discussion for another time though, is if you are in pain, does that pain then mean something different to you? Henrik was alluding to it, and Benam has also put a comment in on it, where acceptable or tolerable pain could be manageable if it has a benefit. So if it works for you, you can probably accept it more. But I guess it's interesting to chat about at some point. Does being in pain change your willingness, perhaps, to work with that limitations that pain would give any people or any person in specific circumstances? I think that's at least what I think when I talk about that predictability of the pain. It's not so much not being in pain that I experience in patients that is useful for them, because I can't help them with that, most patients, but they really feel it useful if they can predict it, if they know that going out for a long walk will predict, if they can predict that will give them pain, that's useful for them, although they will be in pain, but just being able to predict it, I think that's interesting.
Exactly. Just to add a following question to that, because once again I agree with you, but I also think that when we talk about the predictability as well, and this it's very much once again a question of looking into this very complex phenomenon that pain is, and maybe this is also a question of not necessarily moving the bar too far, but just using this understanding of what is it that the patient, where are the patient now, what is it that the patient might be able to do that could just move the bar a little bit into the red area, and what is it the patient will absolutely not be willing to do as a clinician, and then just trying to move the bar a little bit with some exercises and some advice so that they can gradually take on a little bit more control than what they had before.
What I like about these discussions is going up in that meta perspective and thinking about the sort of overarching perspectives or theories that might underlie, or guide us in the clinic. That's always interesting. I know there's a few more questions, but Michael, I also acknowledge that we need to stop at some point.
So I always love when the discussion starts to be good, you get into interesting topics, but I also understand that people are expected that it stopped at 5:30. But of course we had a small intermezzo in the middle. I'm not going to mention that again. So that's why I think it was good that we made it progress a bit longer than ever anticipated. One of the things that I really take from this today, just some of my highlights, at least before I round off and say thank you all for joining in, is that when we talk about patient education, it's not just a direct transfer of knowledge from me to Morten. It's about putting that knowledge into context and make it applicable in the patient's own context, because the clinical situation is just less than 0.5% of a patient's full day. They're out on their own where they have to make decisions on a day-to-day basis. And what Morten talked about here towards the end, like it's almost like Søren Kierkegaard, that in order for us to help another person, we need to be able to understand the other person. It comes back to all this about opening up and understanding why they may not be inclined to do an exercise that is painful, or why they may not be inclined to go out and take a walk today because it actually hurts my neck. And at least this is where I've more in the listening phase and understanding the patient is where I think we can gain a lot in terms of an overall management plan and an alliance with our patient, because we suddenly acknowledge they're the expert and we try to understand their perspective, the lens they see the world through. And it's not just in the patient education side of things. I think, Ben, you touched so nicely on all the aspects about exercise, because exercise is not just about a physiological stimuli that you give a patient. It's the entire context of an exercise and what you give to the patient, what do you tell them. You had the nice example of a person with lateral hip pain. She didn't want to go out sprinting. She was afraid of that. And then your solution was actually to expose her gradually, building up exposure to what she wanted to go back to, but also what she was afraid of. And I think that's a nice demonstration of all the complexity associated with an exercise prescription, that it's not just the load and intensity, it's everything, how we frame it to the patient. I really enjoyed how we had 2 talks and then leading into a panel discussion here towards the end. And this is where I wanted or wished that we had more time, because I'm thinking now we're opening up things that are highly interesting to a lot of us. So hopefully this will be a stimulus for us to say, well, maybe next time it's even more panel discussion and focusing the questions on what it is we all battle with in clinical practice. I want to say thank you to Simon, Ben, and Morten for also joining in and helping share their research and their expertise in this area of exercise, musculoskeletal pain, and just helping people in pain. This will be recorded, and as soon as I get some time to upload the recording, then we'll share a link with everybody that signed up, and also share it on Facebook with the middle part edited out.
Probably an edited link.
Definitely. So thank you all, and have a nice evening.
Thank you for having us. It's been a pleasure.
Thank you.